talking about an introduction to acute kidney injury in the ICU. And obviously I'm not going to be able to cover all aspects of this subject because each one of the objectives will probably have grand rounds of their own, but I'll try to cover the basics and answer some more common questions about this. I have no disclosures to make. There will be, however, a discussion of non-FDA approved use of some medications, and I will refer to that at the time. So I'll start with some very generic questions we always face in the ICU every day. You've got a patient who's in septic shock, slightly borderline oliguric, creatinine is up, potassium slightly up, and we always ask the question whether we should dialyze them early on or whether we should just wait until an urgent indication of dialysis happen. We always have that patient with mixed respiratory and metabolic acidosis, and their pH is borderline, and you wonder whether you should replace their bicarb or not. You also always have that patient with acute kidney injury, and you don't know whether you should diurese them or not because you're afraid that diuresis might make things worse. And part of this talk would be focused on answering at least some of those questions. So those are the objectives of my talk today. I'll be talking about the definition and stages of acute kidney injury, the etiology, and the outcome. I'll also be talking about medical management as well as renal replacement therapy of acute kidney injury. And I will be touching base about whether we should start renal replacement therapy early on versus late in the presentation. So let's get the basics out of the way. What is the definition of acute kidney injury? And I'm sure most of us know this, but to, again, just define the basics, you'd have to have an acute loss of the kidney function. You'd have to have a retention of some waste products, and you'd have to have some sort of dysregulation of the extracellular volume and electrolytes. And those are basically the functions of the kidneys that we know about. Now, this is more of a pathophysiologic definition of acute kidney injury. However, if you would like to know the exact definition of acute kidney injury as nephrologists look at it, then you probably should look into KDIGO. And KDIGO is probably where any nephrologist would first refer you to look into the acute kidney injury or chronic kidney or kidney disease in general. So KDIGO or Kidney Disease Improving Global Outcomes publish guidelines on different aspects of kidney disease management, and they do update them regularly. And this is how they define acute kidney injury. So acute kidney injury is defined by any of the following. So if you meet any of those criteria, so you're good to go. You would have to have an increase in serum creatinine by more than, equal or more than 2.3 milligram per deciliter within 48 hours. So an increase from 1 to 1.2 is not an acute kidney injury. You'd have to have an increase in serum uric creatinine to more than 1.5 times the baseline, which is known or presumed within happen in the last 7 days or so, or more, or less, and or you'd have to have a urine volume of less than 0.5 cc per kg per hour for at least 6 hours, or oliguria, which is often what we first see in the ICU, just because we check the labs for those patients much more frequently than other patient populations, and serum creatinine, as we know, lags behind in change. Now, I just wanted to emphasize this particular number, and I don't know if most of you know that or not, but where does this come from? Why do we aim for this amount of urine, and why do we say that 500 cc or 600 cc is the cutoff point for oliguria? Do we have evidence base for that, or where does it come from? And it comes from basic physiology, because an average American would eat a diet that has protein that is enough to make around 600 to 800 millismoles of waste products per day. And in theory, you're able to concentrate your urine up to 1200 millismol per liter. So based on those hypotheses, you need to make at least 5 to 600 cc of urine a day to get rid of all these waste products that come to mind. However, if any of those two theories is not correct, or those proposals not correct, then your oliguria stat is actually different. For example, if you're eating a lot of meat, if you ate a few steaks a day, then you probably need to make much more urine than 500 cc an hour. However, what's more common in the ICU patients, that if your ability to concentrate your urine is impaired, then you'd have to have much more urine than the 500 cc to be oliguric. to not be oliguric. And that's often what happens with patients in the intensive care unit. You'd often see patients who make a liter, 2 liters of urine, and they're just creatinine and all the numbers are going up, and you wonder what's going on. It's probably the ability of concentration in the tubules. That's what's abnormal. It's not very much relevant to talk, but I just thought I would touch base on it. So, moving on from the definition, we have different stages of acute kidney injury, and those stages are not there for fun. They actually do have implications on outcomes, and we do know that patients with higher stages of acute kidney injury have worse outcome, whether it is mortality or renal outcomes in terms of needing dialysis in the short or long run. And obviously the tables are over there. There are a couple of other definitions of stages of acute kidney injury, but the general theme is that the more creatinine elevation you have, the more the stage up, which makes sense. But you also have to remember that urine output is also part of the staging. So if you're anuric for more than 12 hours, then you pretty much have stage 3. And the reason this is important is there are a lot of studies that look at the outcome and look at when should we start dialysis, and the outcome of dialysis depend on what stage of kidney disease are we dealing with. So a lot of studies that look at early initiation of dialysis look at stage 2, which oftentimes we do not start dialysis for in the general practice. Think about how often you start the dialysis in patients with a creatinine of 2. Or with oliguria for just 1 day. Probably you wouldn't be able to remember any of them, or maybe 1 or 2. And however, some of the studies that look at the outcome of acute kidney injury and early dialysis and acute kidney injury looked at dialysis in those patients. And this is important because it will be part of the bias that I will talk about later. Independently of the kidney function per se, just the mere fact that serum creatinine has increased more than 0.3 milligram per deciliter in 1 day, that has been independently shown to be associated with worse outcome, mortality in some studies, as well as hospital stay in other studies. So just randomly a patient with a creatinine of 0.5 went up to 0.8. This is just an independent predictor of a worse outcome. Now, unfortunately, we often deal with acute kidney injury in the ICU, basically around those stages. And in an ideal world, we should probably be dealing with it over here. That almost never happens. We almost never think about discontinuing nephrotoxic agents when possible in patients who do not have acute kidney injury. But what you're doing really is you're just delaying the inevitable, because ultimately you will just have an acute kidney injury in most of the ICU patients, as we will talk about in a few seconds. Volume status often is not dealt with as aggressive as we should probably. Hemodynamic monitoring and monitoring serum creatinine urine output, we are usually pretty good at that, but avoiding hyperglycemia, we do know that we don't do it too tightly, but we still do it pretty good. However, seeking alternative radiocontrastic procedures often is not the case when someone has an apparently normal kidney function. However, if you think about it, if you do a contrast for 100 normal kidney functions, you probably will induce acute kidney injury in a few of those. And if you just sought alternatives when possible, you may have saved them 1 or 2 acute kidney injuries, but that sometimes doesn't happen. And then it goes along to all the way to the need for renal replacement therapy and when to consider ICU admissions and starting renal replacement therapy. And KDIGO always advised against subclavian catheters placement for dialysis because of high risk of complications related to the line itself and related to central stenosis, which I know infection control personnel usually advocate against, but from a nephrologist standpoint, subclavians are a terrible line to do. Now, it might be helpful to think about kidney disease as a spectrum, and again, we deal most of it with the higher end of the spectrum, but we also have the lower end of the spectrum, and there are some pretty simple stuff that we can think about that can prevent or decrease the rate of acute kidney injury early on in those stages. However, the complications would happen probably as long as you start losing some of your glomerular filtration rate. There are some markers that are new and they're emerging. I'm not going to talk about them right now because there is a huge deal of information. It's all controversial. Nothing has been clinically approved. Nothing is very consistent, but it's there. The data is out there. Some of those markers are very promising, but for the time being, we use the creatinine, which is honestly a terrible marker for kidney disease, but it's the best we've got. And it's terrible because it's late. It happens to worsen much longer after the actual kidney dysfunction has happened. It's very non-specific, it's very sensitive, but we still have to go with it because it's the best we've got. Hopefully someday we will have much better markers than creatinine and it will help us better. Those are just some other markers that have been studied. I'm not going to go into the details, but just so you know that there are other markers being investigated. Now, we do know that it's common. If you ask any intensivist, they tell you how common is acute kidney injury, but if you just want to look at some data, I found a couple of studies that were convincing. One study looked at 120,000 patients, about 60 ICUs in Australia, and 36% of those had acute kidney injury, and that's only in the first day of ICU care. So it doesn't even include acute kidney injury that happens afterwards. And as we know, AKI is associated with an increase in hospital mortality. Odds ratio is impressive, 3.29, and p-value is impressive as well. So it's pretty well established that acute kidney injury is bad, and we're going to talk about what we can do to help with that. Another ICU study looked at about 100 ICUs. Number of patients was much less than that. It was 1,800, and the reason the number is much less is because they looked at the acute kidney injury in the first week of ICU admission, and it looks like that the AKI burden was about just shy of two-thirds of the patients, which makes sense if you think about our patient population, probably more likely. What is the etiology? We always think about it as ATN until proven otherwise, and that's actually for a good reason, because it is almost always ATN until proven otherwise, and estimates vary, but half of the patient, at least half of the patients will probably have ATN, but we also should think about other stuff that might cause acute kidney injury, like vasculitis, AIN, which is pretty rare, and we often overestimate AIN for some reason. We often start discontinuing medication and changing things around for AIN, but a lot of estimates estimated between 1 and 3% only of acute kidney injury causes, and that's not even including causes that, we're not talking about patients who require dialysis, we're just talking about anything that meets the definition for acute kidney injury, even if the creatinine just went from 0.5 to 0.8 for a couple of days and went back on. Arterioembolic as well as glomerulonephritis or vasculitis constitute only less than 5%, so you have to really have a high level of suspicion to consider those. Other databases have suggested about 70% of the acute kidney injuries are due to ATN related to sepsis and hypertension in an ICU population. The database called Picard, or Improved Caring Acute Renal Disease. Those were ICU and non-ICU patients, but still 70% is probably more like it. Now, as stated before, ATN is the most common cause, but it's not the only cause. However, due to the vast majority of patients, especially in the ICU, especially the clinically meaningful acute kidney injury, where you have oliguria or need for a dialysis, mostly ATN, and that's why most of the outcome studies focus on the ATN more than anything else. Now, I divided those into renal outcomes and patient outcomes. They're not necessarily the same. First of all, the duration of the acute kidney injury. Typically, in the classic textbooks, ATN has been described as a process that takes 1 to 3 weeks to resolve. After 21 days, if it's not resolving, then it's not going to resolve. At least that's the classical teaching. That's why you could often hear that if the patient ends up on dialysis for a few weeks, then the chances of them getting off dialysis are pretty minimal, which is true, as was shown by further retrospective as well as a couple prospective studies. It has also been shown to be related to the length of the insult. A lot of data out there suggests that if you have an insult that's related to, say, contrast-induced nephropathy, which usually happens within a few minutes of introduction of the contrast, or if you have, for example, in surgical patients, AKI related to clamming of the aorta and some of the surgeries, which usually takes less than 1 hour, it has been associated with a significantly lower number of days into AKI than, say, if you have a persistent sepsis and shock status. Those took longer to resolve after the elimination of the insult. Data about that is pretty old, but all the newer data, everything new has come over until now suggests that as well. Now, how about the degree of recovery, which we rarely think about in the intensive care unit? What happens to those people when they're discharged, whether they're on dialysis or not on dialysis? And matter of fact is, a lot of these people end up on dialysis even after an apparent recovery of their acute kidney injury after a while. A study looked at about 30, it's not a study really, it's a database analysis. They looked at about 37 1,000 patients admitted to a VA facilities over 70 years, and the primary diagnosis was MI, and they looked at patients with AKI and without AKI, and patients who have AKI were more likely, much more likely actually, to end up on dialysis or with a meaningful reduction in their kidney function, at least the complications, about half of those, as compared to less than 10% of the patients who did not have AKI. Pretty significant outcome. And more impressively, the U.S. Medicare beneficiary claims and the U.S. Renal Data System, which is the federal database for all the renal patients, and basically any patients with an ICD-9 code that suggests kidney dysfunction. Patients who are aged 67 years or more, that's just what the database is, they're 6.7 times more likely to end up with end-stage renal dialysis by 2 years after discharge, even if they apparently recovered. And we almost never know that in our patients. We just get happy that their kidney injury resolved and we discharge them, and we just don't know that they have a very high, much higher incidence of requiring end-stage renal disease after we send them out. And we almost never talk to them about that as well. I think this is the nephrologist's job, but we're still taking care of them, and we just don't know that. Now, looking at the patient's outcome, which probably is more meaningful to an intensivist, if you develop a kidney injury and it required dialysis, then the patient has a good chance of dying. About half of those patients, between 40 up to some studies, older studies suggested 80 and 85% mortality rate. However, the higher numbers, people who suggested more than 80 and 85, were usually dealing with people either in centers that did not have a sophisticated chronic renal replacement therapy options as we do, or it was even before the invention of some of these modalities. So SLIT, to mention one of them, has made a tremendous improvement in the amount of in the mortality expectation for those patients. We may not see a direct effect of it, but it's true. And you could just look at the sepsis mortality numbers, which has come down. Granted, some of that is due to the earlier recognition, earlier treatment, but still, you think about how many patients who died of hypoxemic respiratory failure, who would have died of hypoxemic respiratory failure if we just didn't have the modality to remove fluids of them more gently than say with intermittent hemodialysis. That same database, that the VA database that looked at around 37,000 patients, patients with with AKI were more likely to die. 2.1 hazard ratio. Hazard ratio. And again, that involves all patients. So it's not even specific to the ICU patients. Up to 8 years after ATN, there is still an increased mortality. It's pretty significant. Usually, from a nephrologist standpoint, they usually follow the creatinine for about 2 to 3 years, but there have been some data suggesting increased mortality up to 8 years after ATN. So ATN per se is a big deal. We just might not know it. It affects patients and affects long-term outcome of those patients. Now, this is a more sophisticated study. It didn't just look at associations. It tried to do some logistic regression analysis to see which one of those things is more likely to expect worse outcome. And they looked at not a lot of patients, but 600 patients with ATN. 2/3 required dialysis, and by far, high creatinine levels and, interestingly, development of ARDS along with dialysis have been shown to have the most significant impact on the patient outcomes. This could be to the fact that ARDS is essentially a form of overload, and it could mean that those patients were just having trouble with diuresis. We have now emerging data that diuresis with ARDS, even with low CVB, might be beneficial. So this could be it. Next in line comes liver failure, thrombocytopenia, as well as sepsis, maybe just generally because those patients are just more sick than the other patients, but still, it's worth mentioning. And then age, interestingly, didn't have that much impact on outcome. So something to think about. PN was not really that significant at all, so tells you something, because we often get excited about numbers of PN high, and we just think that patient needs dialysis because of them, and that's probably is not true. Also, we might think about that as not being true, because PN is not really what's toxic. PN is a surrogate marker, much like a creatinine surrogate marker for your kidney function. PN is just the thing that we can measure. Actually, most of the toxins that induce uremia are just not measured, and you don't know what they are. And there have been some studies looking at some markers. Nothing has yet come close to PN, but PN is what we have. So PN alone is not the toxic part. It's not the uremic part. It's mistakenly called blood urea nitrogen because it has some nitrogen in it, but it doesn't cause uremia. Now, those are the basic goals that we all know and we all do, and we'd like to maintain good fluid balance. We don't like our patients very overloaded or very volume depleted. We'd like to avoid nephrotoxic agents, adequate nutrition, treat the infections, and correct reversible causes. All of these things we should do, and there's all the things that you will find at the end of the nephrology consult note. Always avoid nephrotoxic, those medications renally, and those make sense, and I think that most people should do them. However, I will touch base on a few specific questions that often comes to mind when you're dealing with someone with acute kidney injury in the ICU. First of all, diuresis. Should we diurese? Should we not diurese? When is Lasix working? When doesn't it work? First of all, if you have someone who's very overloaded, then you probably should diurese them, unless there's a contraindication for that, like needing septic shock. Does it change the outcome? Probably not. Granted, the data wasn't really that good of the quality wasn't good, that's why I didn't include it here, but there's some suggestion that if you change the acute kidney injury from oliguric to non-oliguric with diuresis, it's not going to really change the outcome much. So Lasix may be used, whether it's going to work or not, for volume overloaded patients. You may delay intubation, but probably not going to change the outcome. And that doesn't seem even to work, or people don't seem to believe that for some reason. About up to two-thirds or more of patients who nephrology has been consulted on usually have already received some sort of diuresis, one way or the other. Whether it was appropriate or not, that was not known, but it's there. So, do we treat AKI with Lasix? There's something magical about Lasix that treats AKI, and some people propose that, some people thought it may be. And before we go into that, let's just have a look quickly to refresh your minds about how does Lasix work. So this is the most famous picture in nephrology. That's the nephron, and you start with GFR here, and then you go all the way. This is where the urine goes. You have a lot of reabsorption and excretion down those tubules. This is your lubricant, and the ascending thick limb, which most of the reabsorption of water happens. Then you have the distal tubule, and then you have the urine and the collecting tubules, and this is all this is all just interstitium, and then this is the medulla and the cortex where you have most of those glomeruli. I don't know when was the last time that you guys saw this picture. I thought I'd just remind you of it, and to remind you that loop diuretics work right about here, and that's where most of the sodium and potassium reabsorption happens. You get reabsorption of sodium, potassium, and 2 chlorides. It's a baggage, so you get all these N, water follows, and that's how you get reabsorption. If you block that, you block the reabsorption of sodium, and that's where you get a lot of more urine, and that's where Lasix work. Now, based on this, there are some theories that propose that Lasix may actually treat acute kidney injury, and one of the theories that it may decrease oxygen consumption. You block in one of the actively working channels, which uses ATP, so you may inhibit ischemic injury there. You may just wash away all these debris from the dead tubule and cause more urine to wash them away and cause less injury. You may inhibit prostaglandin dehydrogenase, reducing the vasoconstrictor effect, causing more vasodilatation, more blood flow, and there's some good data about that in rats, but in humans nothing has really come to nobody has ever been able to prove that it works. So in clinical practice, it does not work. It doesn't treat AKI. And on the contrary, we actually have some data saying that it might be harmful. It's definitely harmful when you're giving it to patients prior to contrast. That's why we give fluids. It may be harmful, but it's definitely ineffective when you give it after cardiac surgery to prevent AKI. And it is ineffective and definitely possibly harmful when given to treat AKIs for any reason. I think they looked at some 5,000 or 6,000 patients for a lot of reasons, and it just didn't work. So basically, no, Lasix does not treat AKI. Is it beneficial at all? Do we have benefits of using Lasix? And this nice review article, which was published about 6 years ago, kind of summarized all these studies that looked at Lasix, and they had a lot of criteria. They had a lot of patient populations, but in general, patients either did better with control or did exactly the same. One outlier here just looked at the study of 10 patients, so it wasn't really that convincing. But in general, it doesn't affect the requirement of renal replacement therapy. It may even harm. It's also the case for all-cause mortality. It does not work if it is not needed. And by needed, I mean if your patient is making urine and you just get volume off of them, which is probably the only reason you should use Lasix. Should we use dopamine? And I'm pretty sure most of you would know the answer to that. The answer is no. This is one meta-analysis that looks at whether dopamine works in patients with acute kidney injury, and so as you can see is no, dopamine does not work. It did not affect the mortality or the need for renal replacement therapy. It did, however, increase urine output, so it got us excited. You can see more urine output after a few days, but does it really affect the outcome? Probably not. Why does it increase the urine output? Probably because it preferentially increases the blood flow to the kidneys. And that has to do with the type of adrenergic receptors that are present in the kidney vasculature. But that's about it. It doesn't really improve your outcome. How about bicarb therapy? It's also one thing that's always been used in the ICU. Does it really work? Should we use it? If the pH is less than 7.1 in basic physiology, it has been shown to affect the contractility of the heart. So I couldn't find any convincing studies saying that it would be beneficial, but it makes sense that it is beneficial, because if you have a pH of 7.1, then your heart will suffer, you will contract less, and you will have worsening shock. There were, however, a couple of small randomized controlled trials that failed to show any benefit of bicarb therapy when the pH is more than 7.1. They were small, they weren't great, they were combined at less than 100 patients, but that's the best evidence we have. So think really hard the next time you're trying to start bicarb on someone with a pH of 7.2 just because they have lactic acidosis. Probably you're not doing them any good. You may even do them some harm, because most of the bicarb will come either with D5 or with sodium, so you're giving them some volume back, giving them some sugar back, so probably not a good idea. How about lactic acidosis? I didn't include that study over here because it wasn't very convincing. It wasn't a good data study, but one study that I could find found that lactic acidosis, treating lactic acidemia with CRRT was not really that helpful. So in general, if you have a lactic acidosis or a respiratory acidosis, bicarb probably is not your friend. If you have a mild metabolic acidosis, bicarb is probably not your friend. You could use it to elevate the pH more than 7.1 merely for the fact that it affects the contractility of the heart. If you're thinking about affecting the enzyme structure and all these things, then you probably are thinking about pHs that are much less than that, like 7.8 and 6.9. But 7.1 is probably the number we should be thinking about. Next thing on the checklist of medical management of kidney disease is Kayexalate, and again,
What are we doing to the
we're probably not improving the outcome. Probably, but again, the data wasn't really that convincing. It was a small study and it wasn't.
No change in mortality, just prolonging it.
You're improving the numbers. You're getting the pH to a better number, but the question becomes is whether it's evidence-based or not, and the answer is probably not. It may be beneficial, it may not be beneficial, so I don't think any nephrologist, when someone who's already started on SLED, would not give them more bicarb if their pH is going down, just because we don't know if it's improving or outcome or not. But until we have more data, we can't just assume starting someone on dialysis just for the mere fact of lactic acidemia does not have any evidence behind it. So is Kayexalate, by the way. Doesn't really work either. It's supposed to be an exchange resin, so it exchanges sodium. It basically dumps sodium and takes up potassium, and when you make a bowel movement, you're supposed to get rid of the potassium. In theory, also could retain sodium and cause edema, and it has been reported that it caused edema in the initial studies that supported it, which I'll get to in a second. But to summarize, before I even get into the details, it's very weak. It requires multiple doses, it requires multiple days. The evidence is very weak, and single doses are usually not effective. So when you see a significant drop in potassium after you give Kayexalate, it's probably not a Kayexalate, it's probably something else. Let's look at the data that supports Kayexalate, and long story short, we don't have a lot of good data. Interestingly, the PIS study comes from 1961. At the time, the rules for FDA approval for medications were much looser than now, and that's how Kayexalate got approved. The largest study looked at only 30 patients with hyperkalemia due to acute or chronic, so not all of them were in the ICU. They were treated with a variety of doses of sodium polystyrene sulfonate. At the time, it was also mixed with sorbitol, which is no longer used. I'll get to that in a second. In 24 hours of therapy, potassium did go down, and most of the patients had at least 0.4 milliequivalent drop in the first 24 hours. However, most of those patients have already received other treatments for hyperkalemia. They got low potassium diet, therapies to lower the sodium like insulin, glucose, sodium bicarb. So all of these things really are confounding factors here. And when you're looking at 30 patients, it's really hard to confound those studies. So we don't know. The second most important study or case series really about Kayexalate came within the same year, 1961, so about 50 years ago. Patients with AKI and hyperkalemia, so more specific study, they were given sodium polystyrene sulfonate combined with sorbitol or sorbitol alone. So that was the control, and they both have some meaningful drop in sodium and potassium. So sorbitol is a laxative. That's basically what it is. It's much like lactulose. So basically, Kayexalate has not been shown to be more effective than lactulose in treating hyperkalemia. However, sorbitol has been withdrawn since then, and FDA has recommended against using it because of the severe complications that comes with it, such as necrosis in the intestinal walls and severe diarrhea. So it's no longer used. So we're just using Kayexalate without sorbitol. It may be effective, but probably more so for the chronic use of Kayexalate, not for the acute. At least we don't have any evidence that it works in the acute, and it does not appear to be more effective than just mere use of lactose or any other laxative for that matter. So until we have further evidence that Kayexalate works, I'm pretty sure we're never going to get that because it's a pretty cheap medication and nobody's going to study it anymore. We probably will never have any evidence to support or to suggest against using Kayexalate. Now, when all of that fails, come to the fun part, which is renal replacement therapy in the ICU. And I just thought I would like to talk slightly about the basics of renal replacement therapy in the ICU, and let's go to the very basics. So you can remove things from a highly concentrated compartment by one of two ways, either convection or diffusion. Diffusion is simple. You have a semi-permeable membrane over there, and you have pores in that membrane, and you have a body of fluid that has a lot of that material, whatever it is. In this particular diagram, it's those small pores, and then if your size of that particle is smaller to the size of the pore in the semi-permeable membrane, it will go through. The stuff that are much larger will not go through. Now, the other way of removing stuff is called convection, and that's if you have a transmembrane pressure. So it's a pressure-based modality. If you have a lot of pressure on this side, then you will convect part of the fluid to the other side, and that part of the fluid will carry some of the stuff that's already in it with it. So you'll have some removal of fluid. Concentration will ultimately drop because you're removing some of that preferentially. But it's not a diffusion. The main difference between those two is that in diffusion you could have both-way movement. In convection you can't, because you can't have a transmembrane pressure both ways. That's important because it is the main difference between CVVH and SLID or hemodialysis. So remember that when I talk about those two modalities. This is simple hemodialysis. This is what we do for outpatient as well as inpatient stable patients. So you get the blood from the patient. It's dirty here, has a lot of waste products, whether it's a fistula or a catheter or whatever it is. It goes through the dialyzer. This is the small cylinder-shaped filter you see at the side of the machine. You have the semi-permeable membrane over here. You have clean dialysate that is being pumped countercurrent to the blood to maximize the amount of time that you have in which the blood and the dialyzer will be touching. And then you will have diffusion of waste products here. And then you will have, if you want to add bicarbonate or even potassium, then you will have diffusion the other way around. And then this is washed out, disposed, and then the clean blood goes back to the patient. This is the simple hemodialysis. This is CVVH, and as I told you, dialysis depends on diffusion of stuff from the blood to the dialysate or the other way around. CVVH is a little different because CVVH actually deals with conviction. So you have the blood coming out of the patient over here, and then you, I'm sorry, yes. So it goes through the dialyzer. There is no dialysate here. It's by conviction. So the pressure is high on the blood side. You convict some of the plasma to the other side of the membrane. You get rid of those toxins, but you can have transmembrane pressure both ways. So you can't really infuse stuff back to the blood. What you do instead is that you have a replacement fluid that runs after you're done with dialysis and before the blood gets to the patient. You replace whatever you want to replace, whether it's bicarb or anything else, and then the blood goes back to the patient. So this is the major difference between CVVH and hemodialysis. SLED actually is a form of hemodialysis. It's just much slower. So it deals with diffusion rather than conviction. SCUF is exactly CVVH, except that you do not really infuse anything back. See, the replacement fluid is negative. So all you do is that you use some conviction to get rid of some fluids. So you only use it if you just want to remove fluids and you have no dialysis indication for dialysis. This is what SCUF is. Now, here we always faced with the question of whether we use chronic renal replacement therapy, whether it's a CVVH or SLED, or intermittent hemodialysis, and we all know the most famous indication, hemodynamic stability. It is probably better tolerated in unstable patients just because the flow is much less. In hemodialysis, you have a flow of up to 500, 600 cc per minute, whereas it's down to 60 cc per minute in SLED. So you can see why it's different in terms of flow. If you have severe volume overload, you'd think that hemodialysis would work better, but actually it's the other way around because your SLED works for 24 hours a day, 7 days a week. Overall, it's more effective just based on the fact that it works for a longer time. If you have very specific indications, like sometimes in the neuro ICU, we want to keep the sodium around 150 for patients with brain edema, so it's easier to achieve that with SLED because it runs in a more continuous terms. So as we said, one of the benefits of CRRT is that you run, or SLED in particular, is that you run at a very low flow. But as you may imagine, that will mean that you will probably have more chance of clotting, because when the blood is just not flowing very far in a very powerful fashion, you're probably going to clot. So you need to use some sort of anticoagulation, which is not needed in intermittent hemodialysis. And this anticoagulation, you could use heparin. It's used in a lot of places. It's not good because you will end up with systemic anticoagulation and with the side effects that comes with it. Citrate is what is being proposed as an alternative to that, and it's not FDA approved for this particular reason. Get that out of the way. It is used, however, in other places, like in blood banks. That's how they actually get rid of the clots in the stored blood. They just infuse them with citrate. That's part of the reason you get hypocalcemia when you transfuse patients massively, because you have citrate in the blood. But the caveat for that is that you need to replace that calcium. I'll tell you why in a second. And that needs a very strict protocol. Fortunately, in Henderford, we have probably one of the best protocols in the nation for replacing calcium, and that means that our SLED is very effective. In other places, it's not as strict. So if you go somewhere else and try to practice critical care and you see patients in SLED, you probably should check their calcium yourself, because the replacement protocol is not as strict as in Henderford. This is a piper that comes from a dialysis filter. There are thousands of those filters in each one of those dialysis filters, and as you can see, citrate is impressively more effective in treating clots than heparin. This is a usual filter with heparin used for anticoagulation. This is your citrate, no clots. And the reason for that comes down to basics, which are this. This is your coagulation pathway. So if you can see, you could have all of these, both extrinsic and intrinsic pathways, but the final common pathway, if you don't have calcium, you're not going to have your factor 10 split into 10A, you're not going to have your prothrombin to thrombin, you're not going to have the fibrin, and you're not going to have a clot. As simple as that. So if you have a zero calcium fluid, that fluid cannot clot or clot. How do we do that with citrate? Basically, citrates find calcium. So this is a simplified diagram of SLED. This is your SLED machine. This is where the blood comes from the patient. If you can see that, this is where you infuse citrate. So citrate binds to your calcium, as you can see here, and then you get rid of it, of your calcium and citrate. So the filter, the blood in the filter has 0 calcium and almost 0 citrate. Doesn't clot, and then you infuse a dialysate, like we said, because it's a form of hemodialysis. So you have dialysate. You cannot have calcium in it because otherwise you'll clot again. And then you do the dialysis, and then you have in this post-filter fluid, you have no calcium and no citrate, and you infuse your calcium back. This is where the tricky part is, because you don't know how much calcium was in the blood, and that's usually estimated, and that's what, when the nurses have the SLID protocol, they can adjust the level of infusion based on the amount, based on the hemoglobin, the bicarbonate as well. And there is a great deal of science behind that. I'm not going to get into it, but basically you can estimate how much calcium you need based on your serum bicarbonate and your hemoglobin and your albumin. This is just for to know what the SLID order looks like. This is what we usually use, 24-hour citrate. We've never used in our treatments in Henry anymore. And this is just other forms of CVVH. And as you can see, SLID order has 2 parts. You have the actual dialysis order, and then you have the infusion. It usually comes with citrate dextrose for 24 hours. So you infuse the citrate and calcium as well. Sodium citrate is rarely used, but it is used, and the theory behind it is that if you have a patient who's very acidotic, then sodium citrate probably will give you less acid load than the citrate, than the dextrose, and then you'll end up with less severe acidemia. That would be the only reason to use sodium citrate. And this is just the actual dialysis order, the actual infusion order. Usually infuse citrate at the rate of close to 150, and then the calcium between 22 and 54, depending on those 4 parameters that I just mentioned to you. The overall, you'll end up infusing around 190 to 200 cc an hour over 10 hours. That's around 2 liters. So that's the ultrafiltration you sometimes see on the machine. And that's just the actual dialysis order. You could control how much ultrafiltration an hour, just your axis. You could control how much bicarb and how much sodium. We do not have phosphate in our dialysate in Henry Ford. That's why we keep replacing phosphorus in dialysis. It is possible to add it on, but it's just not commercially available. So now coming to the infamous sentence that you always see in nephrology consults: no urgent indication for dialysis. So what do nephrologists mean by that? It means that patients do not have any one of those 5s. No refractory volume overload, no severe refractory hyperkalemia, no severe uremia leading to one of those, no severe metabolic acidosis, and some specific alcohol and drug intoxication. Some of those are open to interpretation. Yes, exactly. So some of those are open to interpretation, but in nephrology textbooks it always says more than 6.5 after adequate treatment and or EKG changes. Oftentimes we don't really run into those. I rarely think of situations where someone were consulted with a potassium of 7 after treatment without needing dialysis. So we sometimes stick to those things. Refractory volume overload is open to interpretation. I've found many definitions for that. So doesn't mean dialysis is not going to be done, or it just means that it's not going to be done right now. Now, if we don't have any of those 5, then when do we start dialysis? And that's the tricky part. It's always been controversial, and we have a great deal of evidence supporting one way or the other. Start earlier, to wait until complications happen. I did review multiple studies. I found those 2 studies which were published within the last few months, one of them in JAMA and one of them in New England Journal of Medicine. One of them is French and the other is German. And they looked at this exact specific question: when should we start dialysis? Should we start it once we establish the patient has an acute kidney injury that may require dialysis, or should we just start it if there is urgent indication for dialysis? And they looked at the outcome. Let's start with the first study. It's a French study group that they looked. It's actually a much better study than the other one. It's a multi-center randomized trial, looked about 600 patients. They're similar to our patients, either mechanically ventilated and or on pressors, and they all did not have a potential life-threatening complication naturally, because otherwise they would have gotten dialysis. And they looked at early strategy, which they started with once they immediately randomized those patients to the study. The other arm just were randomized to the delayed onset. They just started dialysis once there is an urgent indication of dialysis, as established by the nephrologist. It wasn't the intensivist who decided. And basic characteristics were pretty similar among both groups. Their SOFA score enrollment was 10 plus around 11 or so. And this is what they came up with. It did not really affect the survival at 60 days. Both groups, whether if you waited to an urgent indication of dialysis happened, or if you just started it after they hit stage 3 AKI, didn't really affect the outcome at 60 days of mortality, really. Interestingly, the early strategy has been actually associated with a lower probability of adequate urine output without the need for renal replacement therapy. In other terms, chances of recovery, or chances of recovery of meaningful kidney function. Few proposed explanations for that. Uremia is an osmotic diuretic, so if you wash away the uremia, then urine output will probably drop. You often see that someone who's non-oliguric, and you dialyze them and they become oliguric all of a sudden, and that sometimes will happen, but it's not true. It doesn't look like it's meaningful. It looks like it just happens, and both patients died at the same rate, and both patient groups, granted it's only been studied for a few months, so we don't know if ultimately some of them would need more dialysis than the others, or would be a mortality benefit after days or after months or years, but this is what we have right now. Now, the other study, or the Elaine randomized clinical trial, was published in Germany. It was a single-sited trial, about 230 critically ill patients, but interestingly, they chose patients with stage 2 AKI, which, if you remember from the definitions, we rarely start dialysis in those patients. You think about when the last time you saw patients on dialysis because they had a creatinine of 2, or if they had oliguria for 1 day, probably not a lot. They'll follow them for about, well, actually enrolled them in about 2 years, but they didn't follow them for as long. They started them early, so they started in the early intervention arm. They started them within 8 hours of within 8 hours of diagnosis of stage 2. The other group, they were delayed, but they did not even wait for urgent indications for dialysis. They just started them within 12 hours of stage 3. Or it was an intention to treat study, so the people who never ended up on dialysis, they were randomized with the delayed group. And patients who end up on the early group, some would argue that they're not sick, but the basic characteristics are actually similar. The primary endpoint was again mortality after 90 days after randomization. And this is the algorithm of exclusion. So as you can see, they excluded a great deal of these patients because of a variety of reasons. And then they screened all these patients with Etiology stage 2. They randomized them to one or the other. And then those are all the patients that were actually randomized to the control group, but they never actually got dialysis. 6 did not even need dialysis. And then a few of them just violated the protocol, and 3 of them died before they started the study itself. The patients with the delayed strategy had at baseline more chronic renal failure, significantly so. Unclear if it's significant or not, but this is the only difference in baseline characteristics. And the urine output and the serum creatinine were significantly they were significantly better in patients in the early arm. So the early arm had more urine output and significantly less serum creatinine, which makes sense. That was the randomization. So their average creatinine was 1.9. Even 2.4 is still early for dialysis in a lot of our patients. So they started dialysis at this point. They were making half a liter of urine a day. Which again, usually we don't start patients on dialysis this early. They did find, however, some outcome benefit with that. It looks like at 90 days, 40% of the early treatment has already died, whereas 60% or 58% almost of the delayed group have died. Is this really meaningful? It looks like it. However, you'd have to remember that those patients were just much sicker, the one that started on the delayed protocol. For what we know, who knew if those patients with the early AKI stage 2 would have progressed into stage 3? Maybe they would have recovered the exact same way that they recovered with dialysis. Maybe if we dialyze both those groups at the same time, they would have the same outcome, just based on the fact that their kidney injury was just never that severe. And when you have a less severe kidney injury, that also sometimes means that you're just less sick or more healthy at baseline than the other people. So there was an outcome of benefit, at least that we can see in the numbers. Is it convincing or not? To me, honestly, it's not. Some people might quote this and might think it is useful, but it's up for debate. Also, interestingly, something to support my my stand on this is that patients in the early group, a significantly more number of them had actually recovered their kidney function at 90 days. So it doesn't even look we don't even know if they needed dialysis in the first place. No, they might have never needed dialysis, those patients. So it brings up the question of whether they should have been dialyzed or not. And the odds ratio is 0.5, so pretty significant. I think that's all I have to say. So if you guys have any questions, I'm happy to answer them. Thank you, Dr. Edelman, for your help with the presentation. You showed up right now, but thank you very much. He was busy with another presentation.